My name is Walter Kinney. I work for the Kaiser Health Maintenance Organization in Northern California. And I was asked to talk about the experience of screening with cytology and HPV co-testing in the real-world setting. I don't have any conflicts of interest with anybody. I'd like to start by recognizing a couple of people who have worked very hard on this without compensation. Helen Dinkelspiel was one of our house officers that is responsible for a lot of what I'm going to show you. And Barbara Fetterman is our data guru in the regional lab, without whom none of this would have been made public. Now, I am not one of those folks that is going to tell you that randomized controlled trials are the only meaningful evidence. Trials are very important, but what's also important is what happens when you turn the thing that you have developed in the trials loose in the population and you give it to every family practitioner that is working in the entire organization and you turn them loose with it. That's a different thing. And I am completely aware of the difficulties with observational data, and I have no reservations about admitting to them. However, I would like to say that observational data should also be part of the discussion about how things actually work. It was 10 years ago this month that we decided that we would offer women 30 and above perhaps cytology and HPV testing. And part of the reason that we did that was that in 1996 we had recommended screening every 2 years to our women, and both the women and the physicians had soundly rejected that. Several years later, most of them were still screening at a 1-year interval because they recognized accurately that 2-year screening with cytology meant an increase in their cancer risk. And the reason that they were accepting of co-testing and of co-testing at 3-year intervals was that we told them that we could accomplish for them the same cancer protection that was available with annual cytology at 3-year intervals using both tests. And this is a graph that simply shows that within 5 or 6 months of starting co-testing, all of the facilities but one were up in the 80 to 90% acceptance range. And so unlike increasing intervals with cytology alone, this was widely and promptly accepted in our population with the assurance that we weren't compromising people's cancer protection. And in point of fact, they actually did do the screening interval recommendations. This is the median interval for almost 250,000 women who had a negative co-test between 2003 and 2005. And in point of fact, that was accomplished without changing the cancer screening, the cancer rates. These are the cancer incidences in 2000, 2001, and so on, forward to 2010, and they have not changed meaningfully. Some things have happened that I can't explain, and part of observational examinations is to figure out what's actually happening in the real world and then try to explain it. These on the left are some of our changes in screening practice, and these are the total CIN3 in cancer diagnosed. And you can see that when we started showing the Cytotex, the HPV results, there was an abrupt doubling in the number of CIN3 diagnosed. The cancer rates have stayed stable, as I've shown you. In addition, as we continued along, we started to do quality control on all the PAP-negative HPV positives. And then in 2008, we told the physicians that they had to biopsy people who were PAP-negative HPV positive ×2. And as you can see, the number of CIN3 diagnosed as a consequence of PAP-negative HPV positive went up 4-fold there. So in 2010, we are now diagnosing roughly 3 times as many CIN3 as we were in 2005. And about 10% of that is from the PAP-negative HPV positive fraction, even though our follow-up is less than perfect. Probably only 2/3 of people are receiving the appropriate follow-up for their PAP-negative HPV positive screens. The reason that the cancer rates don't change instantly is that CIN3 takes a long time to become cancer. If you detect and treat successfully 100 CIN3, what you are doing is preventing 1 cancer a year for the next 30 years, roughly. And that is in the absence of additional screening intervention. One thing that you do see is that you get a little more lead time to figure out who's at risk for cancer. These are women, 136 women who developed cancer, who had co-tests 6 to 42 months prior to diagnosis. And for the squamous cancers, the PAP-negative HPV positive fraction is meaningful. But for the adenocarcinomas, it is the single most important component of recognizing who's going to go on to develop cancer. There are people who go on to develop cancer who are co-test negative in this time period. No testing is perfect. The same pattern is seen in women who develop adenocarcinoma in situ. They don't generally go to colposcopy until they have, or not until quite recently, until they have an abnormal pap smear. But if you look back at 6 to 42 months, half of them were PAP-negative HPV positive. If, in fact, we are going to make headway against adenocarcinoma and adenosquamous carcinoma, which we haven't done well up to this point with cytology, HPV testing is going to have to be included. This is cancer risk over 5 years for 330,000 women, and this is Dr. Kotke and Schiffman's work. This is PAP positive, HPV positive. This is HPV negative, PAP positive, and there is a little bit of risk, mostly initially. But this is PAP negative, HPV positive, and over time it's a big deal. We also get to look at what the cancers look like that are diagnosed following PAP negative, HPV positive screens, and 2/3 of them are adenocarcinoma and adenosquamous carcinoma. Our current method of following these people by sending them away for a year is not perfect, because we look at these and find that more than half of them were diagnosed after a single PAP-negative HPV positive. So when they came back, they already had cancer. And a majority of them were diagnosed within a 1-year interval. So the challenge is to find triage for the PAP-negative HPV positives. And the recommendation for the clinicians is always to do an endocervical curettage if the colpo that you're doing is for PAP-negative HPV positive. This is what happens when people come back and are co-tested again after a PAP-negative HPV positive. Half of them co-test negative. A quarter of them have another PAP-negative HPV positive. When they go to colpo, about 5% of them are CIN3 or cancer. And then the other quarter have abnormal PAPs. Now, I don't see the future very well, but I think that there are 3 issues that need to be addressed. One is screening intervals, another is simplifying the recommendations both for screening and for follow-up of abnormals. And the third one is triage of HPV positive women. The third one's really the most important, but I can't get into that with you in a 15-minute stretch. So we're going to talk about the first 2. You're probably aware that the American Cancer Society recently went from recommending annual cytology or 3-year co-testing to recommending 3-year cytology or 5-year co-testing. And that's perfectly reasonable if you think that 3-year cytology provides annual cancer protection. However, in our hands, it does not. In our hands, after 3 consecutive negative pap smears, your risk of cancer triples between 1-year and 3-year cytology intervals. When we look at a single screen in the Kaiser system, the risk after 1 year after negative pap is very similar to the risk 3 years after a negative co-test. And the risk 3 years after a negative pap is similar to the risk 5 years after a negative co-test. But these two are not the same. So it's easy to predict that what's going to happen in the screened population is there's simply going to be more cancer. And what we've done here is recommended more cancer. And there are some folks who would find that this was not a desirable thing, like the lady in the convertible there, for example. It's okay, you can laugh. Don't fret, nothing bad will happen. The problem is that what I've shown you is just one test, and people are screened over a lifetime, and we don't really have experience enough yet to know what the protection afforded by multiple co-tests is, and it's perfectly plausible that with multiple co-tests we will get back down to the risk associated with annual cytology. All we have is modeling at this point, and this is Shalini Kulasingham's work, and this is per 1,000 women over a lifetime. Q3 year co-testing, you do 825 colpos. Q3 year cytology, you do 758 colpos. But you have half the cancers and half the deaths. in return for another 75 colpos per thousand over a lifetime. That's what the modeling says. But it's just modeling. We'll see what actually happens. It's perfectly plausible that there is additional protection with additional negative co-tests. And the reason to think that is the information from the Kaiser Portland cohort, where PAP forecast disease for a couple of years, but a single HPV test at the outset forecast who was going to get cancer for as long as the follow-up continued, which was almost 2 decades. And half the cancer that was eventually diagnosed in that group was PAP negative HPV positive at the outset. The other issue is simplifying the screening recommendations. And what we've suggested to our docs is that they should do cytology 21 to 24, and that the follow of ascus and LCIL should be rescreening and not colposcopy in the 21 to 24-year-old woman. And there should be no treatment under 25 in the absence of unequivocal SYN3. And we're going to take co-testing down to 25. Here are the reasons. This is Gaia Moore's recounting of 3,795 women 21 to 24 who had colposcopy and biopsy for ascus, HPV positive, or LCIL. There were 0 cancers out of 3,795 women and 2.6% SYN3. And we simply don't believe that this is high enough risk to warrant colposcopy. So the rationale for taking co-testing down to 25 is that the cancer risk 25 to 29 looks a lot more like the cancer risk 30 to 34 than it does like the cancer risk 21 to 24. Screening reduces cancer risk at the age of 25, but there isn't any evidence that it reduces cancer risk under 25. As a matter of fact, there's a fair amount of evidence that says that it does not do that. So if we're going to have to continue to screen under 25, we're going to do as little as possible of it, and we're going to respond as little as possible to the minimally abnormals. If we're going to make progress against adenocarcinoma and adenosquamous carcinoma, HPV has to be included in the screening. Peak age for SYN3 is in the late 20s or early 30s. PAP negative HPV positive carries the most risk of SYN3 in the late 20s and early 30s, and the rate's higher but not unmanageable. In 25 to 29, for us it's 10.1% as opposed to 6.1% in the 30 to 34. I believe that HPV triage is coming, and I think that simplicity equals better compliance. So what's that going to do to our colposcopy rates? Currently we do about 16,000 colposcopies a year. If we stop doing colpo on the ascus and the LCIL age 21 to 24, we lose 800 of those. If we had perfect compliance with follow-up for the PAP negative HPV positives 21 to 29, we do another 2,300 colpos, but at our current rate of about 2/3, it's going to be more like 1,500. And so it's not an unmanageable number. I'd like to thank the organizers for the effort they put into organizing this conference. It's a lot of work to put something like this together, and I'd like to thank you for your attention despite the fact that you're just fed.